I think. Let's try that again. Oh, yeah, just a little lag there. So welcome everyone. My name is Shannon Burke. I am the regional manager for the Central East Regional Cancer Screening Program, or Cancer Program, sorry, which is cancer screening and the Indigenous Cancer Program as well. We're very excited to have you with us today, and I know we have several other colleagues that had accepted to join, and we were just mentioning they're probably finishing up their morning clinical activities and joining us shortly, but we won't delay the presentation. We'll get going. We're excited to have this presentation today talking about the nurse practitioner scope of practice change in relation to ordering of CTs, MRIs. We're excited, as we know that's great care for patients to be able to have that access to those nurse practitioner providers, but also wanted to relate it back to the cancer screening program and the added benefit of being able to order high-risk screening for breast and our lung cancer screening program through nurse practitioners now. So it was a welcome change on July the 1st. And so today we have Dr. Avnish Mehta, who is our primary care physician lead. He's going to speak to us about the lung cancer screening. And we have Dr. Rula Shaheen, who's our physician lead for the breast cancer screening and imaging group. So we're very excited to have both of them with us today. And we'll have Dr. Mehta kick us off with his part of the presentation. There will be about 15 minutes at the end for some questions for each group, and we will be issuing some certificates of completion. So just make sure that your full name is visible when you're signed in. Right now, everybody's is, just so we know whose name to put on those certificates. So just some housekeeping. Over to you, Dr. Mehta.
Thanks. Good morning, everybody. My name's Avnish Mehta, and I'm a family physician, and I'm going to be talking to you today about the low-dose CT scan screening program. We are going to have time for questions at the end, but if you have questions as they come up, I'm totally fine with, please feel free to interrupt and ask them as I go along as well, because sometimes it's easiest to answer while we're on the slide. So please feel free to do that. Maybe just put your hand up in the reactions, or you could write a question in the chat. I can see the chat and have access to that. So I'm just going to go through my objectives today on the next slide. So my main objectives today, I'm going to be speaking to you about to get an understanding of the lung cancer screening pathway, review the indications for low-dose CT, and review the importance of low-dose CT for lung cancer screening and the importance of doing that screening within an organized program. So I'm going to be promoting doing the low-dose CT screening through an organized program. You can order low-dose CT at a lot of hospitals and some outpatient facilities, but I'm hoping to show you today the advantages of doing it through an organized screening program. So we'll move on to the next slide, please. So this just gives you an idea, and I think everyone here knows this, but just to be clear, the burden of disease in terms of lung cancer. So, you know, lung cancer is the second most commonly diagnosed cancer in Ontario. It accounts for 13% of cancer diagnoses, but approximately 24% of cancer deaths. So it's the #1 cause of cancer death in Ontario. And the 5-year survival ratio for people diagnosed with lung cancer is about 20.8%. And in the last 10 years, we have not seen, as we have with a lot of other malignancies, a significant improvement. So one of the factors in this is that people are usually diagnosed at a later, more advanced stage. So low-dose CT scanning, the concept is to detect cancer earlier when treatment is more likely to be successful. And that is the case with lung cancer. So the next slide, slide 5, this slide kind of shows you how they came up with some of the criteria and the program itself. So what Cancer Care Ontario did is they used the evidence from the National Lung Cancer Screening Trial, which was a randomized controlled trial of over 50,000 participants. People were eligible to participate if they were between 55 and 74. if they smoked at least 30 pack years, and they were either current or former smokers who had quit within the last 15 years. So the trial showed that people at high risk of lung cancer who got screened annually for 3 years with a low dose CT each year for those 3 years had a 20% relative reduction in cancer mortality. That was compared to people who were screened in the same program 3 years with a chest X-ray. So the numbers needed to screen to prevent one lung cancer death in this study was 320. So for every 1,000 people screened, there were 3 fewer lung cancer deaths in the low dose CT arm than in the chest X-ray arm. So based on this, we came up with, the Cancer Care Ontario came up with the recommendations as follows. Lung cancer screening should take place within an organized program. Low dose CT should be the screening modality for high risk populations. Chest X-ray should not be used for screening. And this, I just alluded to one study over there, but there's been multiple studies to show no benefit to chest X-ray for lung cancer screening. And smoking cessation should be embedded in a screening program. So some of you might ask, well, why don't we do opportunistic screening? But what I mean by opportunistic screening is ad hoc screening which is done outside of an organized cancer screening program. Well, patients are typically selected for screening in opportunistic screening at the convenience or preference of the healthcare provider, rather than being invited to screen using an organized population-based approach. So opportunistic screening is also likely to occur in the absence of a defined pathway for follow-up and recall, and there may not be monitored for quality. So an organized screening program gives us important benefits, such as it ensures that appropriate populations are screened at recommended intervals, conducting appropriate and timely follow-up of abnormal findings, and implementing ongoing quality monitoring. So implementing organized lung cancer screening will ensure greater protection against potential harms of screening, and I'll talk about that later. But organized lung cancer screening has mechanisms to ensure that the CT scans are using the appropriate low-dose radiation, and they're done without contrast, ensures the scans are interpreted by radiologists who have received training to read low-dose CTs, and it uses an algorithm for management of patients with lung nodules. So this minimizes the risk of unnecessary follow-ups or invasive diagnostic testing. So we reduce our chance of overscreening, we have better follow-up, we have a lower chance of complications and quality assurance. And just for context, a diagnostic CT has 4 times the radiation dose as a low-dose CT, just to give you some context there. Next slide, please. So this just gives you a high-level overview of the screening pathway that people will follow from the point of referral to potential diagnosis. So staging and treatment, and then staging and treatment for lung cancer. More detail on each of these steps in the pathway we're going to go through in the rest of the presentation, but this gives you an idea of what goes on. So now I'm going to talk a little bit about the benefits of lung cancer screening, and I think I've touched on all these. So detection of lung cancer at an earlier stage, treatment is more likely to be successful. It has been shown to have a reduction in lung cancer mortality when we treat earlier. There's direct access to smoking cessation services and resources. And when applicable and needed, there's a smooth transition to the lung cancer assessment program. But we, of course, need to talk about the potential harms. Well, of course, there still is radiation exposure in a low-dose CT, and it is more than a chest X-ray, about 15 times more. But again, like I mentioned, it's about a quarter of that of a diagnostic CT scan. You can get false positives, and this can result in unnecessary diagnostic assessments or sometimes even unnecessary surgeries. In the national lung screening trial that I referenced earlier, the false positive rate was very high. It was about 24.2% of scans were considered positive across all 3 rounds, i.e. over the 3 years of screening. And 96% of those positive scans did not lead to a diagnosis of cancer. So this is a concern because false positive results, like I said, can lead to unnecessary follow-up procedures. But it's important to understand that in that study, their definition of a positive scan was very broad. So it included nodules, which, based on the algorithm, would just require follow-up scans at the routine intervals, and would not need a further diagnostic assessment or any kind of biopsy or surgical assessment. So based on their broad criteria of how they defined a positive and a false positive, the false positive rate was very high. But as I'll show you later, the false positive rate is not as high now because we're using these diagnostic algorithms. So the nodules are being followed in accordance with the score. This score gives them a classification, and then follow-up is based on those criteria. So only low-dose CT scans that meet the threshold score are considered positive. So the false positive rate is significantly less. Now, the other risk, of course, is overdiagnosis. So identification and treatment of cancers which would not have come to attention of someone who had not been screened, but would not have become clinically relevant. So who should be in this program? Well, remember, I'll just go to the, yeah, thank you. Remember, this is a screening program. So it's not appropriate for anyone with symptoms. So if you have a concern based on symptoms, you would refer as you previously would have for appropriate imaging or referral. Potential symptoms, and I think everybody on this call would know this, new cough, change in cough, dyspnea, wheezing, hemoptysis, new finger clubbing, suspicious lymphadenopathy, dysphagia, weight loss, or if they have any paraneoplastic syndrome. They will not accept for screening if the patient has experienced either hemoptysis or unexplained weight loss, more than 5 kgs is their definition, in the past year. And in addition, if they have a history of lung cancer or are already under surveillance for lung nodules, we suggest the request is they not be referred and rather just continue with those pathways. So I told you now who shouldn't be in the program, but let's talk a little bit about who can be referred. Well, the referral criteria are current and former smokers between 55 and 74. That age range was based on the original study that I spoke about, who smoke daily for at least 20 years in their lifetime, but they don't have to be consecutive years. Those patients then are referred for a risk assessment by the team. We have found that 2/3 of people referred are eligible for screening as long as they had met the initial referral criteria. But it is important that your patients understand when you refer them that not every patient who's been referred is going to get a low-dose CT, because for some people, based on the algorithm, it doesn't meet the criteria or the threshold that we feel that the studies have shown would show it to be a benefit to them. So the algorithm uses all sorts of things. These are just a few of the examples. Uses their age, their smoking status, history of COPD, their personal history of malignancy, their family history of malignancy, et cetera. But it's more in depth than that. So we go next slide, please. So this all goes into a risk prediction model, and then they get a risk score, which is their probability of developing lung cancer over the next 6 years. And so based on the study, it showed that if they had a greater than 2% risk of developing lung cancer in the next 6 years, they would benefit, statistically speaking, from the screening. So this is actually a model more sensitive than the National Lung Cancer Screening Trial discussed earlier. So the number needed to screen in that study, as I spoke about before, to prevent one cancer death was 320. In this model, it's currently 233. So next slide, please. So how to refer? Well, or who can refer? Actually, I made a typo there. Well, any physician or NP can refer, even if they're not a primary care provider. If you're not their primary care provider when you refer, if you indicate who their primary care provider is, they would copy them on all communications. You'll see on the form that there are authorizations from the referring physician or NP for baseline low-dose CT scanning, ongoing screening, and follow-up of nodules as recommended by the radiologist. The program, you're also authorizing the program to facilitate bookings of low-dose CT scans. And it confirms that they are ensuring that the referring physician or NP is responsible for ensuring appropriate follow-up of incidental findings. It's similar to your ODSP authorizations. Finally, if your patient has had a chest CT in the last year of referral, or they're being referred for a chest CT between appointments, the request is that you notify the program. So as I already mentioned, the difference in radiation between low dose CT and chest X-ray. Go to the next slide, please. It's just mentioned here that it is safer because it uses less radiation. So you're going to get a report. The report is going to have the screening results, which tells you the size, characteristics of lung nodules, and the next steps based on their score. The score is called the Lung-RADS score. What follow-up is needed for that is arranged by the site, but it's also indicated on there what follow-up is being arranged. Then, of course, there's going to be a section with incidental findings. So these are abnormalities unrelated to the lung cancer seen, to the findings seen on low-dose CT. So these can be coronary artery calcifications, aortic aneurysm, osteoporosis, etc. It is the responsibility of the referring physician or NP to ensure appropriate follow-up or management of incidental findings. So incidental findings will be included in the radiology report that is sent out to referring physicians and primary care providers. If there is an actionable incidental finding, the screening navigator will send an additional communication to the referrer, physician or NP, to remind them about the incidental findings. By referring, you're confirming that you are responsible for the incidental findings. However, primary care providers should also follow up with the patients, even if they weren't the referring physician or NP, because they will also be sent the incidental findings as well. Physicians and NPs are requested to confirm receipt of notification regarding these actionable incidental findings. So next slide, please. So this is the communication pathway. You make a referral, there's a risk assessment. They do smoking cessation counseling for people who are currently smoking. Low dose CT if they meet the criteria, and then of course they're referred on for diagnosis and treatment. I'm just going to talk a little bit about the smoking cessation program. The smoking cessation program is offered to all current smokers. And if the referred patient is ineligible for screening, they still, of course, will be, and they're currently smoking, referred to the smoking cessation program. Now, if an eligible patient declines a smoking cessation, then they're still, of course, told that in the future you can still refer back. The primary care provider and the referring physician or NP are told that as well. And even if an eligible patient for screening declines screening, everyone in the circle of care is informed of that, the referring practitioner as well as the primary care practitioner. Oh, one more thing I want to add is that patients do receive a call about 3 days after their low-dose CT from a navigator to review their scores and their next steps. Not regarding the incidental findings. They won't discuss those. They might mention, oh, there's some incidental findings you got to discuss with your primary care practitioner. But for the findings which were related to the lung or lung cancer screening, they will give them their scores. They'll put it in some context for them, and they'll tell them the next steps. Because we, of course, understand that once a patient has a low-dose CT scan, there's understandable anxiety about the results. So we don't want to delay the process of them getting some information too much. So now, I think last slide or second last slide. We'll just go to the next slide. Thank you. So this is just a referral form, and I don't think it needs much explanation. It doesn't have anything really on it that I think you wouldn't expect on a pretty standard referral form. It has not been updated yet to include NPs, but I'm sure when this gets updated, I don't think these forms have been updated since the pilot was started a few years back. But when it gets its next update, I'm certain it's going to include NPs on it. So that's all I have to say. I'll probably pass it on to Dr. Shaheen, unless anyone has any questions now. Otherwise, I'll pass it on to Dr. Shaheen, and we will still answer questions, both of us, at the end. Thank you.
Thank you. That's a great talk, Dr. Mehta. Let me just share my slides, see if I can bring it up again. Okay, well, thanks again for having me here and welcome everybody. I'm going to talk about multimodality breast imaging approach for the new change that we have for the nurse practitioner scope of practice change. The objectives of my talk today is to go through the following: discuss breast cancer screening for the average risk and high risk populations, illustrate breast assessment pathways, which is diagnostic workup, highlight role of multimodality breast imaging with focus on problem solving all the way from mammography, ultrasound, and MRI, and how to go back and forth, explain reports, results, and discuss management next steps. With that, we will review some most common breast MRI indications. So the essential role of primary care providers in breast cancer screening is the following: identifying screen-eligible populations and recommending appropriate screening based on guidelines and patient history for both the average risk and high risk patients, managing follow-up of abnormal screening test results. Lack of continuing care with the primary care provider is an important risk factor for never having had a screening test. And, it's really sad that a lot of, lately we've seen after COVID, a lot of patients come to the breast assessment center and they have no primary care, they have no nurse practitioner, and they have no family doctor to go back to. So that's actually a very big challenge currently in getting the patients close the loop on their care. So recommendation of a trusted primary care provider is strongly associated with cancer screening uptake. And I'm going to move on and talk about what's early detection of breast cancer. It's a combination of screening and effective early diagnosis. So until breast cancer can be prevented, early detection is critical. And this will decrease costs, suffering of patients, and the healthcare system. And as we all know, the most widely used modality is mammogram, which basically takes the population to stage 1, meaning that we really see it only on the screening mammogram and the patient doesn't feel the lump or doesn't feel the symptoms for breast cancer. Ontario Breast Screening Program, as I said, has, as you know, both arms of average risk and high risk. For average risk, it's recommended that the woman usually would have every 2 years a mammogram. Those women are asymptomatic, who are at average risk for breast cancer, and who are 50 to 74. And there are some criteria for women below 50 and above 74, but that's not included currently in the OBSP recommendation. We still ask those women to discuss their risks with their primary care physicians and nurse practitioners. The increased risk, which basically will take the woman from having the mammogram every 2 years to a 1 year, if they have high risk pathology reasons or lesions, or if they have family history. The increased risk, which means sometimes we as radiologists do what we call 1 year recall, if the breast density is more than 75%, or if the radiologist or referring primary care provider ask for that annual screening mammogram. Maybe they have different philosophies. And above all, even if the patients want to have that every year, we cannot say no. Risk factor, which is mainly breast density, as you know, you're going to have probably some discussions with your patients on this. And I would highly recommend to have a better understanding on breast density and what does it mean, and what sort of options are available for the patient. There's lots of hype on social media about this, and it's beyond the scope of this talk, but I'm happy to address it in another setting, because now we are including the breast density in our reports. So women want to know, what does it mean? They want to know if there is an alternative option for mammography if they have dense breast. As you can see here, we can see the cancer easily in the fatty breast while it's embedded in this breast. I also want to make sure that you are comfortable and familiar with the BI-RADS system, which is the breast imaging reporting and data system. So we use the numbers just to make it easier to communicate and easier to enter on ICMS. The most important thing you need to know about screening is the fact that women can have only 3 options on their screening mammograms. Either it's negative, which is a 1, or if there is a benign finding that doesn't need any further workup, but we have to mention it, It's BI-RADS2, just like sometimes we mention intramammary lymph node in an unusual location, or a mass that has been biopsied before and it happened to be benign. So sometimes we mention it and give BI-RADS2. The most important BI-RADS is 0 on a screening mammogram, because that means that there is a finding and the workup is incomplete and the woman need to come back to get further imaging, whether it's mammo only, mammo and ultrasound, or sometimes even ultrasound only. What you shouldn't see in a screening report, and that's a problem, is a BI-RAD3. BI-RAD3 should not be given on a screening mammogram, because that means that the woman had been worked up and a follow-up has been recommended based on that. So do not accept a BI-RAD3 on a screening mammogram. Always question it. As for the screening modality, probably you are familiar with the website. I'm not going to go through it. As I said, there are some guidelines all the way from 40 to 74, and discussing it with the clinician between 40 to 49 and above 74. According to the Canadian Task Force on Preventive Healthcare, so far MRI is not used as a screening modality for the average risk, but we see a lot of requisitions from oncologists, I would say, mainly because women probably had breast cancer with an occult mammography cancer. So they feel that the follow-up for those survivors is worth it to be with MRI. So we take it on case based. I'm just going to move forward with the breast self-examination and clinical breast examination and what are the recommendations. According to the Canadian Task Force on Preventive Healthcare, they advise not to do the breast self-examination for women, and also they recommend not routinely performing clinical breast examination alone or in conjunction with mammography. Let's have a quick peek on the high-risk OBSP screening guidelines, which is very important because now I think you are going to probably order those screening MRIs in addition to the screening mammography for women identified to be part of the high-risk program. However, if these women cannot have MRI for some reason, like there's a contraindication, like pacemaker or having metal in their body, or they have severe claustrophobia or some hearing or skull-based issues, we offer doing bilateral screening with breast ultrasound, which is very specific only for the high-risk women. We start doing both mammography and MRI at the age of 30 all the way to 70, and then we stop the MRI at the age of 70 and offer only digital mammography. Over 75, again, it's a discussion between the woman and her referring provider. Just want to quickly show you an example of screening mammogram where basically this woman is 43-year-old. She's part of the high-risk program. You can see that it's heterogeneously dense. It's very hard to see the cancer. When she had her breast MRI, screening MRI, we saw that dot of enhancement, focus of enhancement in the left breast. You can see it here. The dynamics are concerning. We took her and did a what we call second look ultrasound. And this is very suspicious with posterior shadowing. The mass got biopsied and it turned out to be cancer. We leave a clip usually when we do ultrasound-guided core biopsy to help the surgeon localize the cancer, and it was removed. So this is a big advantage for women with occult cancer on mammography, and the breast MRI actually detected the cancer at very small size. Let's talk about the breast assessment and the diagnostic workup. So women will get that either when they are called back from a screening mammogram or if they present to you with clinical signs and symptoms. And when we call patients back from screening, we basically call them for the following findings. Could be a mass, asymmetric breast tissue, microcalcifications, architectural distortion, and sometimes we see skin thickening or nipple retraction. So more than 50% of breast cancer patients have clinical symptoms or signs, just so you know. I mean, that's not surprising. Timely and accurate diagnostic workup with image-guided biopsies are crucial for early detection of breast cancer, and this is important also for our quality reports. having all these kind of wait times and KPIs, we really have to, and quality indicators are very important to make sure we close the loop on these women care in a timely fashion. The biopsies we offer are ultrasound-guided biopsies, stereotactic biopsies, and MRI-guided core biopsies. And we usually use the modality where we best saw the abnormality. And to touch a bit on what modalities we use diagnostic mammography, targeted ultrasound, and breast MR. And a little bit on some of the indication. We use it for problem solving. Let's say we see something on mammogram, but we couldn't see it on ultrasound, or the patient has a palpable lump and nothing on ultrasound and nothing on mammogram, and she's probably nervous about it. Sometimes we end up doing the breast MRI to see if there is something that's occult on other modalities. It's the most common reason we are doing the breast MR currently is for preoperative assessment to make sure that the staging is done, especially in heterogeneously dense and dense breast, or if the mass is posteriorly located in the breast and we want to see if there's an invasion into the chest wall or pectoralis muscle. In patients with lobular cancer, automatically, regardless of the breast density, we like to do breast MRI to rule out breast cancer in the contralateral breast because it's with increased risk for the contralateral breast. And then when patients have neoadjuvant chemotherapy, in addition to the ultrasound, we do breast MRI. I'm just going to show you quickly a couple of examples where a woman would have a mass here in the right upper outer breast. And then she had targeted ultrasound. It's a speculated mass on the mammo, suspicious. Actually, the triangle that you can see indicates that the mass was palpable. And then the ultrasound was done. Sometimes we like to see on the 3D mammography, which is tomosynthesis, that's available in some centers, as you know, in our region and across Ontario. It's becoming very popular. It helps us have better assessment, especially for asymmetries. So that mass on the tomosynthesis it's showing us that it's actually invading into the pectoralis muscle. And here's the ultrasound. It's really based almost on the pectoralis muscle, as you can see it here on the CT. This is the needle going through the mass on ultrasound, and on MRI, as you can see here, it is actually the enhancement going all the way into the pec muscle. Here are some pictures of the biopsies that we do. This is MRI-guided core biopsy. The woman would be facing prone into the coil, and this is a grid that will help us decide the location of the lesion. Ultrasound-guided needle biopsy. This is a stereotactic biopsy. The woman will have it under compression, under mammography, and the machine would make a stereotactic localization, and the needle would be advanced toward the calcification. Sometimes I just want to talk about the importance of timely referral for second look ultrasound. This is a woman with, she's 63, with history of invasive ductal carcinoma in the left breast. And when we did the evaluation for the breast MRI, we saw that she did have a nodule enhancing in the right breast. So the next step is to not just to jump into doing the breast MRI guided biopsy. Actually, sometimes we see them really well on ultrasound, just like in this case, we see the nodule, the woman gets the biopsy done, and it's going to change management, obviously. So it's very important to be aware of the results of the MRI and the recommendation and act upon them fast to make sure that the surgery is not going to be delayed, or not just the surgery, like the decision, the management will be made, whether she will need the surgery or not, whether she's going to have neoadjuvant prior to the surgery or not. And yeah, unfortunately, that nodule in the right breast turned out to be invasive ductal carcinoma as well. This is an example showing how a large mass in the left breast with a lymph node was followed up following neoadjuvant therapy and completely dissolved. Another unfortunate case for a young woman who was pregnant when she presented with breast lumps, and she had breast implant saline here, which complicates the evaluation of the mammography. So MRI was problem solving and telling us the extent of the disease. And here's on MRI, we can see that she actually had multiple enhancing lumps and ended up with mastectomy. all of them turned out to be cancer. I want to go through a couple of clinical examples where women would present with some findings, such as this woman who had bruising and some redness in her breast. And we always get tense about redness because we think it's probably infection most of the time, versus we want to make sure it's not inflammatory carcinoma or something that's going to fungate through the skin. So when we did the mammogram, luckily she had fatty breast, and as you can see here, there is some asymmetry overlying the pec muscle, and this turned out to be within the context of the clinical history, and she had some bruising, she bleeds easily, and it was a hematoma. We have to make sure that we follow this up until resolution, just like in lung nodules when we see them, or lung, pneumonia. So after 3 months, she had another mammogram and it cleared up, so she's safe. Another patient who had a large hematoma after a biopsy for microcalcifications on a stereotactic core biopsy. We did the ultrasound, we aspirated it to make sure that she will clear her breast fast, and that's the hematoma being drained. Remember the male breast, it's breast cancer, yes, it's very rare, but we need to be aware of some of the symptoms that they will come with, such as swelling, especially in the retroareolar region. And usually it's a gynecomastia. It looks nasty on the ultrasound. However, mammography is the way to go. It looks like a flame-shaped appearance. He also had a palpable lump in the lower breast, turned out to be a sebaceous cyst, and we easily saw the duct that connects to the skin, and that gives us a definite diagnosis for sebaceous cyst. Gynecomastia, as I said, it does look sometimes like cancer for us on ultrasound. However, it is the most common presentation for palpable lumps in men. However, we need to keep in mind men with some risk factors who can present with irregular masses. So this is atypical appearance for gynecomastia. There is some echogenic halo around it, and that turned out to be, unfortunately, a breast cancer in a male breast. We also scanned the axilla. The lymph nodes have thickened cortex, so this was invasive ductal carcinoma. It's rare, but we have to keep it in mind. Common clinical breast complaints warranting imaging are the following: pain, but please, like with breast pain, it has to be focal. You cannot, try your best not to send patients with generalized breast pain. We actually don't accept those. If there is focal pain that's not related to menstruation, yes, we sometimes fit them in. However, we do recommend that clinically assess the patient and assess their risk. They are really clogging our system, and most of the time, 99%, they are negative. Lump is a valid reason for referral. Nipple discharge, nipple itching, skin changes or redness, asymmetric size, which is new, and axillary lumps. For example, this woman here has an asymmetry in the size of the breast. However, on further questioning, when the patient got referred, that basically this is the way her breast looked like, but somebody pointed that this could be abnormal. However, this is very common, and she shouldn't be alarmed, and no imaging was necessary. As opposed to this woman here, she has new bilateral nipple retraction, some redness you can see here radiating from the areola, and it's very concerning. And when she had the imaging, this turned out to be, unfortunately, bilateral breast cancer. The asymmetry in size, when it becomes abnormal, the breast has increased in size with redness and some changes around the areola, and this was basically new change for the woman over 3 months, and it is inflammatory breast cancer. The redness, another area of redness in the outer breast, the patient had symptoms that are suggestive of infection. So giving antibiotics will and cover patients with whatever necessary for treatment, and make sure that she comes back after resolution of the symptoms to make sure that there's nothing left in the breast and obscuring a cancer. So there was no imaging. Would be important just to rule out abscess and help with expediting response to treatment. Another complaint would be my breast is shrinking. So that's another concerning finding. This woman here, that's the normal size of her breast, and the other breast got smaller in size. Actually, the bruising here on the side was from the recent biopsy at that time. and it was hard rock-like breast, and that was actually breast cancer, unfortunately. Just wanted to show you the asymmetric size in breast, but also if you look closer, you see the peau d'orange and the difference between the two breasts, and this is actually a sign of inflammatory breast cancer, or stage 4 even. Quick last few minutes on the importance of multidisciplinary breast cancer care. When it comes to breast cancer, I think that's the backbone of the effective and successful screening program. Without having a diagnostic and therapeutic and follow-up kind of system and pathway to connect the doc, really it won't be a successful program. So along the cancer continuum. So we talk about prevention, screening, diagnosis, treatment, survivorship, and obviously hospice as well for end-of-life care. The core team are the breast surgeons, radiologists, pathologists, oncologists, radiation oncologists, and breast navigators. We usually have them on weekly basis at our hospitals. I will have to say the most important person in this kind of setting is the breast navigator. It's very important to have a breast navigator who has a crucial role in patient-centered high-quality care for breast cancer patients. She glues, or he, it depends, she's the glue to bring it all together, ensuring that patients are timely booked for further imaging, biopsies, and follow-up. I would highly recommend that you connect with wherever you work with a breast navigator, and usually they have the answers for a lot of questions related to some debatable questions or vague cases. It's very important to connect with and find a breast navigator. So in summary, breast cancer screening in Ontario is divided into both. We discussed the average risk and the high risk population, so important to know the different type of screening modalities available, and the span of time in between the images, between the mammography and whether you need MRI or ultrasound. The multimodality breast imaging utility is necessary in closing the loop on patients' care with clinical breast signs and symptoms, or if they are called back from screening. Breast MRI is both a screening and diagnostic modality. Thank you very much. I'm going to stop sharing. Okay.
That was excellent. Thank you so much to both you and Dr. Mehta as well. We'll open it up for any questions. Are there any questions from the group? Your presentations were just all informative. Sorry, go ahead, Natalia. Were you going to ask a question?
Dr. Shaheen, you mentioned not accepting or questioning BI-RADS 3 on receiving reports. So you mentioned that usually if it's a BI-RADS 3 on a screening, then something would be arranged by radiology. So if we get the reports where if follow-up was not arranged, that's when we would have to reach out. Is that what you meant?
Sorry, my mute button didn't work. Thanks for the question. I'm glad that you asked it because I need to clarify that further. So BI-RADS 3 exists, obviously, but it should come after a diagnostic follow-up. What I meant is that there shouldn't be a screening report that has BI-RADS 3. That's when I say really question that kind of report and make sure that you clarify with the radiologist why did they have to put BI-RADS 3. And having said that, I don't think our radiologists in Ontario use it anymore. It's just, again, it's a word of caution because they understand to be part of OBSP, radiologists reporting for OBSP, they know the rules, but this is just in case for you guys to make sure that if you come across it on the very rare occasion, that it shouldn't come from a screening mammogram. Does that answer your question, Natalia?
Yes, so that we can still get those reports, but that would be after some sort of diagnostics had been done. And
absolutely, exactly. Oh yeah, you'll see a lot of BI-RADS 3. Like, we as radiologists can be sometimes insecure and we ask for a lot of follow-ups, but no, I'm just kidding. But like what I'm saying, you're going to see a lot of BI-RADS 3, which basically important to make sure that the woman is coming back for them. sometimes, because really we're trying to minimize unnecessary biopsies. This will help us minimize the number of biopsies.
Understood. Thank you.
Thank you.
Dr. Ray, you have a question?
I do. Thank you. Both of the presentations were excellent. I have a question about breast cancer screening in the 40 to 50-year-old age group.
You go ahead.
So I know it's outside of the guidelines, but I'm just interested in knowing what your opinion is with the information that came out earlier this year about the Ottawa, the research that was done out of Ottawa around breast cancer screening guidelines.
Well, I do wear multiple hats. So today I'm wearing my hat as an RBIL, but like I am very comfortable to say that I do, like I personally get my screening done when I hit 40, correct? So women between 40 to 50, their concerns and their breast need to still be addressed, correct? Like we can't just, even if they're not part of the OBSP, they can still get access to get screening. So OBSP doesn't say they cannot get screened. They just say they're just not included in the program. That doesn't mean they cannot get screened. Based on the Ottawa study, yes, it's Ottawa study and actually many other studies, like even if I'm talking at global levels and US level and even national Canadian studies, there is a benefit from the screening between 40 to 50. And I think there is work going on in Ontario Health to look at what's the best recommendation about how to tackle this issue. How can we be more inclusive? So if you're asking my personal opinion, yes, women will, I've never ever declined or turned away women less than 50. We actually recommend annual screening when they come in for screening, if they are referred by their physicians. I think the only challenge that they cannot self-refer in Ontario. They need either a nurse practitioner or a physician to refer them to get that. That's the only difference between women above 50 and under 50 when it comes to screening, and the fact that they can have annual screening. Any other questions for Dr. Mehta?
That's fantastic. Thank you so much again to both Dr. Shaheen and Dr. Mehta. I think it was a fantastic presentations from you both, and a very helpful learning for me and hopefully the group as well. As we mentioned, we will issue certificates for attendees. So I do see there's one individual with just a first name. If you could put your full name in the chat so we could make out your certificate for your full name, that would be fantastic. And we thank you all for joining us today. Hope we answered some questions for you.
Thank you very much. Have a nice weekend.
Thank you so much.